room and see if anybody who's supposed to be presenting virtually needs help getting into the breakout room. I'm just gonna be right back.
Okay, sounds good.
Okay. I'll go as far as I can from you so I can hear. Okay. Thank you, ladies and gentlemen, our loyal participants. Thank you very much. For those in the room, and especially as well those joining us online, we're going to be having a very exciting session in which we're going to be looking at the abstracts, the conceptual thinking behind much of our program and policy decisions. We have our first presentation up on the screen, and that will be followed, we hope, by 8 more presentations. I was thinking that once we have done our presentations, we can then hopefully open the floor for some Q&A, okay? If there are any burning issues or any point that needs further clarification online, please put that in the drop box, or of course if you're in the room, just raise a hand and then we will deal with it. If there are no issues of immediate clarification, then we will proceed through each of our esteemed presenters here and online, and then we'll take it from there. And of course, everything that is up here will, in due course, be uploaded. It will be online for further review, and you will also have the contacts, the emails, so you can follow up with myself as the moderator, or indeed with each of the presenters. And only one last thing left to say is that my name is Dr. Gary Jones, and I am the Senior Humanitarian and Security Advisor based in Geneva for UNAIDS. So that's me. I don't want to do any more talking, so I'm immediately going to hand the floor over to our first presenter. If you would just kindly introduce yourself, your organization, and it's over to you. Thank you.
Well, thank you very much. Good afternoon to everyone. My name is Jacques Cole. I'm a psychologist and therapist, and I work in Berlin. And I more precisely work for Checkpoint Berlin, which is a queer sexual health center in Berlin, and we do provide PrEP, PAP, HIV and STI testing and STI treatment as well. And today I'm very happy to be here and to talk about a program we've been having during the pandemic. During a certain time, we did HIV treatment for free for people who did not have health insurance in Germany. And today I'd like to give you some more information about what we were doing during what we're doing in this program. So let me see if this works. Perfect. Okay, so a few words about the background of our program. So for those people who don't know Germany that well, I can tell you that there can be very high administrative barriers to make access to HIV care in Germany. So it can be very difficult for people living with HIV and having no legal resident status to get a health insurance coverage. So this creates gaps in care that mainly affect people with low incomes. So that's basically always the case. So even now, after the pandemic or after the several lockdowns, there's still the situations that migrants, foreign students, foreign sex workers, that they often rely on importing HIV treatment from abroad in order to have their treatment in Germany. And during the pandemic, there, as you all know, there have been travel restrictions. So people living with HIV in Germany, some of them stranded in Berlin, and they couldn't go back to their country of origin in order to get HIV treatment. So they were stuck in Berlin and couldn't go back and see a doctor in Brazil, for example. In addition to that, there were tightened custom restrictions that led to a breakdown of personal self-sufficiency system, which means that treatment was, or the HIV treatment pills were stuck in the customs, so they couldn't get them out. So family members or friends sent the medication from abroad to Germany, and the patients couldn't get them out of the customs. So these people were at risk because they were risking of not getting their HIV treatment. And we reported this problem to the local Berlin government, and we were very lucky because they understood the problem and they gave us some funding so that we could initiate a program at Checkpoint. And we did that between June 2020 and we did it until the end of 2021. And we made possible that people living with HIV in Berlin could easily access medical care. So basically, patients were seen at least once by a social worker and by a medical doctor in order to clarify whether they might have access to health insurance and to see what medical care was needed. So basically, we checked if they had possibility to get a health insurance in Germany, and simultaneously, they have been talking to a medical doctor in order to see how their situation was and in order to prescribe them HIV treatment. So here's some information about the patients we were seeing. So the majority of the patients were men having sex with men, and almost half of them were between 30 and 39 years old. 63% had an income that was lower than €1,000 a month. So they were that mostly were poor people, and 23% did not have any income at all or social welfare benefits. So they were very vulnerable people. So they had no money, they had no health insurance, and they couldn't get their medication from abroad. This shows how people got in touch with us. So half of the people contacted us directly, and the other part contacted us via other NGOs or medical doctors. Here's some data about the health situation of the people living with HIV which came and asked for help. So you can see that 67% had more than 500 CD4 cells, and 10% were below 300, and 26% were even below 200. So some of them were in a very bad condition. And when it comes to viral load, 58% had a viral load below the detection limit. So some of them had their medication for quite a long time. Then COVID came, and then they had no possibility to get further medication. And others were not under the detection limit, so they were not undetectable. So it's a very mixed picture. Some of them were in a very bad health condition, and some came very early. So they said, oh, in 2 weeks I won't have any medication, I need your help. And then we were able to prevent that there were breaks in treatment. Here's some other information, interesting information about patients. So 16% reported to be involved in sex work. 1 patient was pregnant. 5% had problematic substance use. 23% had made use of our interpretation services, which we offered in Arabic, Russian, and Farsi. At the first contact, 80% had no health insurance, and 20% did have health insurance, but it was not covering HIV medication. 14% received their HIV diagnosis less than a year ago, and even some patients come to Checkpoint, got tested anonymously, got their diagnosis, and then told us that they didn't have a health insurance, and then we started our program, which was a good thing. So they got under one roof the HIV diagnosis, they got some social service in order to get the health insurance and some support for their legal status maybe, and in addition to that they immediately started their treatment as well. And most of our patients have been living with HIV for more than 2 years though. Okay, and then at the end of the program, 66% of the patients receive medical care through either a health insurance or special municipal funds, which means a different funding than we had. So we managed to get a long-term perspective for 66% of the patients who have been seeking help. 32% had left Germany either to return to their home country or to travel to other countries where medical care is easier to obtain, or were lost to follow up, and 1 patient died due to an overdose. Okay, so these are our lessons learned. The restrictions from the COVID pandemic have significantly worsened the situations for migrants living with HIV who do not have access to health care. And there's still a high need to offer medical care to people living with HIV without health insurance coverage. And access to HIV care means that no medication alone, it must include language mediation, social workers, and psychologists. So our recipe was that medical doctors, social workers, and interpreters, they were coordinating their work, and coordinating their action resulted in a better understanding of the patient's situation. And even for the patients, it was easier because they only needed to come to one place, and then they got all the services there. So they could see a doctor, a social worker, and they could also get some psychological support if they wanted. So integrated care is the provision of seamless, effective, and efficient care that reflects the whole of a patient's medical and social needs. So that's why we combined HIV medical care and health insurance counseling, and we provided all services simultaneously under one roof. That's what I just said. And we are very glad that we today can announce that by then we only reached a limited number of people living with HIV, and that we have in the meantime, so with the beginning of this year, launched a new HIV program for people living with HIV and having no health insurance coverage. Thank you very much.
Thank you very much. Thank you. There's a lot there, and I particularly like that on the social insurance. That was fascinating. Would bear with us, please. Now, I'm never quite sure who's in the room and who's online. Excuse me. I have on my cheat sheet that the next presenter is Landam Shea. Is Landam in the room? Gentleman at the back, if someone might translate for me, how do we know if they are online? Could somebody help me?
Hi. I'm going to go ahead and check to see if they may be online in a different room, and I'll be right back.
There's only one then online. Okay, well, which being the case then, that's all right. Can I ask your own good self to present next? Absolutely, the floor is yours. Thank you.
Is that yours or is from the... Can I use it? Yeah, thank you. Mine is...
You need it on the...
How
You
do...
have the slide deck? Right.
Mi nombre es Valme, soy la quinta. Sí. Vale. A ver.
People online learn this.
Vale. ¿Aquí se me ve? Vale. Okay. Good afternoon to everyone. My name is Valme del Rio. I am an internal medicine resident of preventive medicine and public health, and the study that I present to you today has been developed in the surveillance service of the Andalusian Regional Government's Health Department. It is a socio-economical approach of the monkeypox outbreak in Andalusia as of July 2022. We, the authors, declare to not have any financial or personal interest developing this work. So, where do we start from? As we all know, on May 2022, the UK Health Security Agency reported several cases of monkeypox. All these cases had no history of recent travel to endemic areas or contact with previously reported cases. Since then, many countries have reported more than 20,248 confirmed monkeypox cases. As of July 12, 2022, 2,447 confirmed monkeypox cases had been reported to the Spanish surveillance network. The vast majority of them appear to be related to specific sexual risk behavior, especially among men who have sex with men. It seemed necessary to assess this outbreak from a public health perspective, taking into account the socio-demographic characteristic of the affected population and whether it may be related to their socio-economic level. So, what did we do? We did a cross-sectional study with all monkeypox cases from Andalusia of July 12, 2022. Using a geospatial analysis with QGIS free license software, we merged the economic data and epidemiological data using average income per person information from our National Institute of Statistics. In order to calculate our incidence rate per 100,000 inhabitants, and per 100,000 males aged between 15 and 69 years old. What did we observe? On July 12, 2022, we got 232 monkeypox cases that had been reported to the Andalusian surveillance network. 228 of them were males. 219 of those reported to be men who have sex with men and had sexual practice risk sexual behaviors. 92 of those had HIV co-infection at the time they were contacted. When analyzing the incidence rates by province, we found that the province with the highest rate was Malaga, with 7.62 cases per 100,000 inhabitants, which rose to 20.63 cases per 100 males aged between 15 and 69. In second place was Granada, with 3.04 cases per 100,000 inhabitants and 8.38 cases per 100,000 males aged between 15 and 69. Finally, in third place, we found Seville, with 1.8 case per 100,000 inhabitants and 5.04 cases per 100,000 males aged between 15 and 69. Finally, when analyzing the economic data, we categorize Andalusian population using their average income per person by quintiles. We got that quintile 1 was the one with the lowest income, and quintile 5 was the one with the highest income. We observed that there was a ascendant incidence gradient. As we got a higher income, we got a larger number of cases. And we found that 52.59% of the cases were grouped by quintile 4 and quintile 5. And the incident rate ratio between quintile 5 and quintile 1 was 1.95. So based on these results, we reached the following conclusion. As of July 12, 2022, monkeypox in Andalusia mainly affected men who have sex with men in a 94%. HIV prevalence in this subgroup was 42%. Malaga, Granada, and Seville were the provinces with the highest incidence rate, and unlike other diseases, incidence seemed to be directly proportional to a higher average income per person. Thank you all for your attention. Apologize for my English, and it's been a pleasure being here today.
Sorry, you were saying that we have a colleague online? And so for my colleague online, as soon as you do come online, please do so and let us know your name, please. Corey. Corey.
Yeah, hi, can you hear me?
There's Corey. Okay. Corey, welcome. The floor is yours. Take it away. Introduce yourself. Let us know what we'll be listening to, what you will be teaching us. And as I was saying, we'll go through this and then have a Q&A at the end of your session. So thanks very much. Over to you.
Great, thank you so much. So my presentation, my first presentation is on HIV stigma and punitive laws and policies and barriers to HIV care in 5 African fast-track cities. And as a little bit of background, legal and policy environments can either mitigate or exacerbate stigma and discrimination for people living with HIV, as most of you or all of you probably know. And this is across the spectrum of seeking, accessing, and utilizing healthcare services. We also want to draw attention to the Global AIDS Strategy, which calls for a reduction to less than 10% of stigma and discrimination experienced by people who are living with HIV and or who are members of key populations. So our method for this abstract, we used data from 3 different data sets that were part of 2 distinct projects that we worked on. The first is a quality of care survey that happened across several fast-track cities, surveying people living with HIV directly. We also last year did an LGBTQ initiative where we surveyed key informants rather than the population itself. We surveyed key informants from 50 fast-track cities on LGBTQ issues, including HIV. And we also conducted an assessment at that time of laws and policies relating to HIV, LGBT issues, sex work, and other related topics. So the results here from our quality of care survey first, we had over 400 participants from each of the cities that I included in this analysis, which you can see listed there. And for each city, there were between 12 and 23% of people living with HIV who said that they felt unwelcome in the healthcare facility in which they receive HIV care, which is concerning to us and certainly above the 10% target that we've set to reach by 2026. Most cities also had large number of people who feared disclosure of their HIV status by a provider. Lagos had the highest number with 78% of respondents who said that they had this fear. Here you can see the details going city by city. So the numbers are relatively close for the percent of people who felt unwelcome, between 12 and 23%, whereas there was a lot more variation in the number of people who feared that someone at the health facility would improperly disclose their HIV status. This was not a concern for almost anyone in Maputo, but it was a very large concern in some of the other cities. Now, we also looked at our policy analysis that we had conducted for, sorry about that. There we go. We looked at our policy analysis for the cities that we had conducted for the other project. And we found that in each of these cities, there were not laws at the national level to prevent the criminalization of HIV exposure, nor were there non-discrimination laws for key populations, and there also were not laws that legalized or decriminalized sex work. We looked at the national level since these are typically issues that are decided on the national level. We also, I looked at the key informant responses that we received for these cities. We had 13 key informants who spoke about issues related to the illegality of sex work, police treatment of LGBTQ people, and sexual orientation and gender-based discrimination as being problems for their communities. Here you can see we did some open response questions and some Likert scale responses. So here were some of the responses, the numerical responses that we received from people. This was on a scale of 1 being not a problem and 4 being a serious problem. You can see that intersectional discrimination and mistreatment of LGBTQ people by law enforcement were some of the top ones, but there were several here that were tied, including criminalization of sex work, mistreatment of sex workers. Of lesser concern were laws criminalizing HIV exposure and non-disclosure of status, but I think it's important to note that a lot of times prosecutions related to that are done with general laws and not necessarily laws that specifically criminalize HIV exposure. So this can be an issue even in places that don't have a law that explicitly criminalizes HIV exposure or non-disclosure. So that may explain why that was considered a lesser concern. So in conclusion, none of the cities that were included in this research are approaching the global target yet of less than 10% of people living with HIV or members of key populations experiencing stigma and discrimination. Obviously, we only looked at a couple of factors, feeling welcome in a healthcare facility and not fearing disclosure of HIV status. There are a lot of other questions that can be done related to stigma and discrimination, some of which we included in the other study when we asked key informants. But these are just a few examples of some of the issues that people living with HIV are facing that are preventing us from, approaching meeting this target unless there's a lot more action that's taken with respect to stigma and discrimination. And that's done in a holistic way that accounts for the identity of the key populations. All 5 of these cities lacked key laws and policies that could help to address the issue. Obviously, we know that law and policies alone don't end stigma or discrimination, but they do send a message of inclusion, and they also provide some recourse for people who do experience these. And we have also found that advocating and enacting these changes could help cities in meeting their anti-stigma goals by 2025 and beyond. And the LGBTQ health equity portion of this research was funded through Deep Healthcare, so I wanted to acknowledge that. Thank you.
Thank you very much, Corey. Absolutely straight to the point. Really appreciate that. I see a gentleman, and that's Dash, isn't it? Dash says, did I do any justice to your name? I hope I did.
It's totally fine, yes.
Great. Can I please ask you to introduce yourself and your topic, and we'll go straight ahead. The floor is yours.
Excellent. let me go ahead and just introduce myself, and I'll share my screen and go through my slides. My name is Dashiell Sears. I'm the North American Regional Director for Fast Track Cities. I'm based here in DC, and I'll be doing my presentation. Let me just go ahead and bring that up for us. Can everyone see my slides? We'll see my slide.
Yes, we can. Go ahead.
Excellent, thank you. So my presentation is on the impact on municipal HIV funding due to COVID-19 related and national funding constraints. See if it will move for me. There we go. All right, so just some brief background. So with a history of HIV and public health, cities in the global north have relied on financial commitments from federal governments. The commitment coordinates with municipal funding to sustain HIV responses, and COVID-19 imparted an unexpected financial shock directly to the global economy and specifically our health systems. So we began developing an HIV barometer. We sent it to fast-track cities across 7 countries: Canada, France, Germany, Italy, Spain, UK, and the US. And at the time, it was around 57 cities that we contacted. So this survey was meant to be measuring the impact of COVID-19 against the HIV funding, whether it was the effect of COVID-19 on city-level HIV funding, city-level HIV responses, or any ongoing commitments to funding HIV at the city level. We developed this survey as a Likert scale for responses and contacted local stakeholders, including public health officials, community-based organizations, clinicians, service providers, and patient advocates. These are the individuals that were most likely to know more about their specific public health funding in relation to their HIV sources, their HIV services, and the communities which were affected by those services or were meant to be reached by those services. They were also likely individuals who had either a say or had some sort of weight behind the public health funding from their city or around the budgets in their city. So for results, overall, respondents generally felt that decreased HIV funding would result in increased HIV and AIDS-related mortality as either somewhat probable or probable. 66% believed that COVID-related budget cuts would place social supports at risk. So as you can see from the graph, the largest response for what would be placed at risk just due to funding cuts based on COVID-19 restrictions was through social support services. Following that, for things like HIV prevention and research, outreach to key populations, and mental health services. For the impact of COVID-19 on municipal HIV funding, results showed that the impact felt by respondents was generally significant, but that it would be short-term, lasting no more than like 1 or 2 years, which is hopeful that it would only be about 1 or 2 years. So we have yet to see the true depth, but the respondents felt that they could overcome that generally within 1 to 2 years. A plurality of respondents believed that COVID-19 would have a somewhat significant impact on commitment towards HIV funding. And what we meant by commitment was the efforts and influence of local government officials to placing replenishment dollars back into specifically HIV responses at the local level. This was felt the greatest in the United States, which felt a 36% reported somewhat significant and 19% reported significant impact on municipal commitment to HIV funding. And finally, for the results, we were able to pull several conclusions. That budget cuts based on COVID-19 are having a continued negative effect on municipal HIV responses, and strategies to minimize this negative impact should be further explored. Leveraging and maximizing resources should be top priority to ensure HIV services are maintained. So that was the end of my presentation. Thank you so much. We can move on to the next presenter.
Thank you very much indeed. Wonderful. Any quick point of clarification required from anyone? I'm talking to the people in the room, and I wish I could see everybody online. I can't. But if anyone is online, just raise a hand, please. Then thank you. Thank you very much. Just stick around. We'll be having some Q&A in a short while. Can I please ask the gentleman at the back, do we have other people online? Could somebody help me out there? All right.
Hi, everyone.
Thank you. Thank you very much for jumping in. Sorry, it's an exciting thing, this, because we never quite know who's going to pop up next on the screen. So it's wonderful to see you. Please take the floor. It's all yours. Thank you.
Hello, colleagues. Can you hear? Can you see my presentation?
Yes, we can. Thank you.
Okay, thank you. Let me introduce myself. My name is Lyudmila Lehkostup. I am head of the Department of HIV Prevention Program and Non-Medical Support People Who Live with HIV, Public Health Center, Minister of Health of Ukraine. It's an honor to be here, and thank you very much for the opportunity to present the experience of my country. I would like to present the impact of the Russia full-scale invasion of Ukraine and on sustainability of HIV prevention services for key population in fast-track cities. Ukraine has one of the world's highest HIV incidence rate, with more than 50,000 new infections per year, and the second highest prevalence in Europe and Central Asia, with more than 250,000 people living with HIV. On this slide, you can see the Ukrainian cities that signed the Paris Declaration. In Ukraine, epidemic concentrate among key population. In recent year, we have made significant progress in reach key population of HIV prevention services, which influence on the development of the epidemic and improve quality and increase life expectancy. HIV prevention program for key population in Ukraine are coordinated at the state budget level and financed from a state budget. Since 2019, Ukraine has been making a transition HIV prevention program from a donor financing to the state budget financing. To the formula 20, 50, 80% to the end of 2020. In 2021, prevention services were fully covered by a state budget. On this slide, you can see the transition of funding by year. Unfortunately, in this year, 21st of February, Russia launched a full-scale invasion of Ukraine, which affected and changed the source of funding to from state budget to the global fund. On this slide, you can see the percentage of key population covered by prevention program for annual indicators, and you can see the program which coordinate by state demonstrate stability even in wartime. This approach makes it possible to provide basic HIV prevention services in a period of uncertainty. We analyzed the impact of the war on the sustainability of state prevention program in fast-track cities, compare data for the period February till May 2021 to the same period of this year. The presented result demonstrates the stability of the system of prevention services even in a period of crisis for the country. In fast-track cities, it was possible not only to maintain services at the pre-war level, but also expand the number of clients these services. For example, in Kiev, you can see in Kiev and Odessa, the number of people who inject drugs increased dramatically by 85% in Kiev and 12% in Odessa. In Odessa city, the number of sex workers increased by 73%. Only in Mariupol, where active military operation took place, the number of clients decreased by 79% among people who inject drugs and 65% among sex workers. This systemic approach and state coordination of prevention program ensured the stability of HIV response system even the wartime. This approach will ensure a reduction in new HIV infection among key population in future. I would like to thank the heroic efforts of social workers who provide services in difficult time for Ukraine and risking their lives every day under bombing and shelling. Glory to Ukraine, stay with Ukraine. Thank you.
Thank you very much indeed. Now, you probably won't see this, but in the box below you, we have the next speaker. Thank you very much for that. Please can you say your name again, because if I have a go, I'm likely to destroy your name, which I would hate to do. Please could you say your name again?
Hello, dear colleagues. My name is Alexandra Denisenko. I'm from Ukraine too. Please for me to report after my colleague from Ukraine, but I'd like to apologize in advance if I couldn't finish my report because of last massive shelling of Russia on Monday and Tuesday. We have not sustainable connection, internet connection and electricity, but still I'll try to finish my report. Here I represent one of the most successful NGOs in Ukraine, Light of Hope, which works for more than 20 years, not only as HIV service organization, but also works a lot in one moment please, I will share my presentation. But also work a lot in advocacy, especially related to public health, in particular regarding the promotion of sustainable HIV systems. The experts of the organization took part in not only in piloting transition plan, but also in designing the transition plan model for Ukraine. This model assumed a gradual transition from donor to budget financing in the period of 2018-2020. To provide services in 2018 and implement the first phase of transition plan, two models were developed, centralized and decentralized The main task was to choose the optimal model, to analyze the pilots, to choose the optimal model, and to implement the best models throughout the Ukraine. In 2018, two regions were chosen. In Sumy, centralized model was piloted, and in Poltava, decentralized model was piloted. Based on the results, our experts, together with Public Health Center and the main GF recipients, have created a model for further implementation of Ukraine. In 2019, procurements of service were made through electronic system Prozoro. Also, the strategic group was set up to coordinate the process of transition, to deal with operational issues, to respond to challenges, to remove the barriers. About 100 million hryvnias has been allocated for the procurement of services in 2019. Regional NGOs became winners of tenders and started to provide services for state funding. Thereby, prevention and care support in the last year was fully financed. HIV prevention and care and support services was fully funded by state budget. So together with government and non-governmental organizations, Ukraine managed to create a model of transition plan that was most optimal for the HIV service area. The e-procurement mechanism is transparent and competitive, so we can get the best quality at a reasonable price. Participants in the process are all potential service providers, so we can get the best. The winner can be organization of municipal institution, businesses, or NGOs. This model was approved in legislative acts of Ministry of Health, Cabinet of Ministers, and others, and can be the basis for adaptation and implementation in the region of Eastern Europe and Central Asia. The model of services procurement encourages the state to optimize its financing to buy the necessary services at a reasonable price from quality providers. Representatives of communities or other participants are not discriminated in newly created market because the criteria, standards, and procedures are clear and approved on the legislative stage according to the legislative acts. Thank you for your attention. I'm happy to finish my report.
Thank you so much indeed. Yes, and thank goodness that you are safe and we're able to continue and to complete. Thank you very much. Our hearts go out to all our esteemed colleagues and friends in Ukraine at the moment. Ladies and gentlemen, distinguished guests, I have on my list two more presenters, one of which is Landam, which according to my cheat sheet in front of me should be in the room, but I kind of gather Landam. Everybody's looking around for a Landam. We don't find one. Okay. Landam, wherever you are, we wish you well. Okay. I also have as well, Corey, you have already very well spoken to us. I actually have you down for two presentations. So Corey, if you are still with us, I have you down for a second session. Is that correct? Are my notes right?
Yes. Hi, can you hear me?
We are all privileged. Then once again, sir, the floor is yours.
Thank you. Let me pull this up really quick. Yes, I do have a second, oops. Sorry, I have a little trouble with my slide. I do have a second presentation. It's related to the first one. So I can kind of save us a little bit of time with some of these slides. Let's see. Okay, hopefully you can see that now. So this study is looking just at the LGBTQ research that I mentioned from my previous presentation, and looking specifically at the association between discrimination and quality of care. This was across 50 fast-track cities versus the other abstract that I presented was just looking at 5 from which we had data from both data sets. This is looking at 50 fast-track cities that cover all of the regions. So let me see if I can advance this. So I'm going to skip over my background and the methodology here, as I mentioned last time. This was with 275 key informants across 50 fast-track cities, and we used Likert scales as well as open response questions. And what we found was that we looked at different forms of discrimination in the survey, as I alluded to in the previous abstract. We found that all types of discrimination that we examined were associated with the perceived quality of primary care for LGBTQ people, as well as with the perceived quality of HIV-related care in particular. The types of discrimination that we measured here were sexual orientation-based, gender identity-based, HIV status, and what we called multiple forms of marginalization, which we explained, could be intersectional discrimination facing racial and ethnic minorities or other people with multiple marginalized identities. Sexual orientation-based discrimination had the strongest association with HIV care quality, while HIV-related discrimination had the strongest association with LGBTQ primary care quality. So there was kind of an inverse relationship there that might be a little counterintuitive, but I think just goes to show that there's a really symbiotic relationship between HIV and LGBTQ related discrimination, and that these two things go really hand in hand together. I have data from each of these 4 forms of discrimination. So here you can see that as sexual orientation discrimination was considered to be more problematic as you go down the list, the quality of primary care for LGBTQ people, as well as the quality of HIV care declined. So we had, the scale here was 1 to 5, 1 was poor and 5 was excellent. So as you can see here, for example, among those who found that sexual orientation discrimination was really not a problem in their city, HIV care was rated between good and excellent. Whereas for those who said sexual orientation discrimination was a major problem in their city, HIV care was rated right in the middle at a 3 between poor and excellent. And here you can see a similar trend with respect to gender identity-based discrimination, that the more problematic that it was considered, the worse that LGBTQ primary care and HIV care were considered to be. Same thing here with HIV-related discrimination, although as you can see that it made more of a difference with respect to LGBTQ care than it did with HIV care in particular. And finally here with respect to discrimination based on multiple forms of marginalization, we have the same pattern. So as a couple of quick conclusions, the association between LGBTQ and HIV-related discrimination really shows the importance of advancing anti-discrimination measures for key populations, including LGBTQ folks, as well as for all people living with HIV. As I mentioned in my previous presentation, just changing the law, of course, is not going to end discrimination, so we need to be looking at holistic ways to address stigma and discrimination in society. And to make sure that we're accounting for the full array of people's identities, because as this showed, there is, certainly a relationship here between LGBTQ-related discrimination and HIV-related discrimination, and the quality of both of those types of care. So everything either improves together or stays stagnant together. We have a lot of recommendations that we published in a report last year where we looked at this data, and some of these include to focus on eliminating inequities within the LGBTQ population where discrimination is most pronounced. So that would include gender minorities such as transgender and non-binary folks, as well as racial and ethnic minorities and other groups depending on the local community. One of the interesting things of this study is that there's not a lot of globally comparable LGBTQ research, and those identities and what the terms mean vary greatly from one place to the next. So it's hard to compare between one study and the other. So something that's a limitation of our study, but also a strength of it is that, we did try to use the framework and the same terminology across all of these places. Also improving data on the holistic needs and experiences of LGBTQ people. That includes health and stigma and discrimination, as well as other factors in their lives. And ensuring non-discrimination where we can. And this can include a lot of action taken by cities and municipalities, which of course is especially relevant for our conference, even where the city or municipality may not be able to ban discrimination in the same way that a national government can, or a constitutional provision can guarantee equal protection. There's still the possibility to do a lot, including some things like training public workers, requiring that service providers be trained, etc. That is it.
Thank you, Curry. And thank you, everyone, here in the room and online. We have the floor, and it's open for discussion, for Q&A, for comments, for constructive criticism. We would like to hear from you. Anybody, it's easy to do in the room because you raise a hand. I'm wondering how I'm going to see those online if they have an issue. Again, colleagues at the back, how could they monitor that?
We do have a chat box online through Zoom, and we can see if someone asks a question through that chat box.
Thank you, Dash. But we don't see on the screen in front of me. I'm not seeing that, so that's my only concern. You might where you are. Do our colleagues with the IT see the comment box? Okay, so thank you, and I hope I got you right. The feedback we've got is if anyone online would like to raise a point, make a point, then please just simply come online and verbally make your point, which is great, so we don't have to do the reading in the Dropbox, so just come online and shout it out. So, the floor is open. Yes, ma'am, we have our first. Please, go ahead. If you could just kindly introduce yourself, your organization, and then your question. Thank you. Let's do one of these. Hang on. Well, I've walked all this way, so you've got to have a comment now.
Hi, sorry, I was going in between rooms because there's so many interesting presentations, but a few of us came and I think the order's changed, and it was, could we get a copy of the monkeypox in Andalusia slides? Thank you. Gracias. Yeah, sure. I was just very interested in some of the challenges and the successes you had in your approach to the outbreak in your part of the world.
Okay, sorry, what was the question? Okay, it was a socioeconomic study, so it's true that we didn't get the interview of patients. They are made by sanitary districts, and we got all data from our Andalusian Surveillance Network. It's an online app where our epidemiologists can upload their interview and all the data that they collect, and then we can watch it and we can study it. So we got it and we merged it with the economic data from INE, or National Institute of Statistics, and we did it in a geospatial software. So what we found is, as of July 2022, we got more cases in higher average income per person areas. We can do a larger research with all the cases that we have now to see if that is maintained, and also to approach the socio-demographic characteristic of population, to watch if there's still a high prevalence in men who have sex with men, or if we have any other subgroup, and study the HIV co-infection prevalence. I don't know if that's, yeah, okay. Thank you.
Any other point in the room? Yes.
Okay. My name is Leili Wahiniar. I am the Strategic Information Advisor from UNH Indonesia. I would like to ask the colleague from Ukraine. I'd like to know more about the methodology to get the finding related with the transition plan. Yes, please. Thank you.
Okay. Of our two colleagues from Ukraine, this was concerning specifically the transition plan. Can you please come back online so we can see you? Yes, thank you very much.
Thank you. Hello. Can you repeat your question because I didn't check?
That's okay, that's fine.
Yeah, I'd like to know more about the methodology to do the, what do you call it, the study about the transition plan. Thank you.
You want to know more information or what? Sorry, because something's wrong with connection.
It's on the methodology that you deployed as you found your facts concerning the transition plan, as you built the transition plan. The methodology.
We use our national system and explore national system. It was easier to calculate because we managed this system on national level. I didn't check this question. What do you mean? If you sorry colleague, if you want more information, I leave my mail, and you can write me, and I give some more detailed information. If it's okay.
No, thank you very much indeed. No, thank you. So, as you can, so we'll make sure that you have the context, so that you can have that bilateral discussion. So if you, I suppose, into that Dropbox that we can't see, if you would be so kind as to drop your email addresses so that we could follow that. I think that would be a good start. Thank you very much. Thank you. Colleagues online.
I'd like to point out one thing. I think we have Landon Shea. Is Landon Shea online in the room with us?
No, we went searching for Landon, but we did not find them.
Okay.
So sadly, that was the one presenter that we have not been able to hear from. Are you in touch with them?
Well, it looks like that there's someone in the virtual room who may be it says the name is Landon from Recap Plus, but I'm not sure if that's the Landon Shea that we're looking for.
Anyone here? Anyone online? This is what happened the last time we asked. There was that sort of deathly silence afterwards.
Okay.
Sadly. Okay. Colleagues online, great if we could hear from you. Our IT experts said just shout out, come online. You have the rights, so admin rights. Come online if you have any questions, any points. As you're trying to work out the IT, and being someone who is challenged regularly by IT, my sympathies go out to you. I have a couple of points, and I'm going to throw this open to each of the presenters, and I also ask the audience as well, just to kick in, if you can. I'm wondering specifically about the data, because we've got some very rich information. As they say, the graphs and the stats, they've been very convincing. But if you had to say, what is the key piece of information that you need to form the basis of your advocacy to policymakers when it comes to public health financing? When we speak of HIV, when we speak of emerging pandemics, be that COVID-19, monkeypox, SARS, what is the crucial piece of information that you need to relay to the policymaker? And that policymaker can be the local mayor, the local provincial council, that could be your minister of health, whatever it might be. I'm going to, as I say, I'm being a bit of a bully here, so I'm going to immediately pass the microphone over.
Yeah, thank you for that question.
And again, just remind us your name, organization.
Yeah, my name is Jacques Cole. I'm from Berlin. I work for a sexual health clinic in Berlin, which is called Checkpoint Berlin. Maybe I'd like to talk a bit more about monkeypox. The big problem we had, that the German government was ordering monkeypox vaccines, and they stored them for a very long time in the fridges, and they didn't give them out, and that was very disappointing. So the key message I would like to give to our government is that we are already working with the key populations. We are a community-led organization, and we are in contact with the key group and the key population and the target groups, and we are already making the work, and it's you can, yeah, the key message would be to the government to say that we have access, and we are happy to help, because yeah, it was difficult to get the vaccines, for example. So that will be one of the key messages.
Thank you. Passing it down the line. Okay. You can introduce yourself.
Okay. My name is Balme del Rio, and I'm here as a medicine internal resident of preventive medicine and public health. And I don't know if I get the question.
What's the key message from the data we know? What's the key message that you would take to policy decision makers?
Okay. I think that HIV or monkeypox or SARS-CoV-2 are diseases that we don't fully understand yet, because they are emerging one, or because they are diseases that affected specific communities, subgroups. And I think we have to put more resources on public health in order to study it as an holistic term. I don't know if, yeah, because they are not just diseases or diagnostic or treatment. We are talking about people. We are talking about ourselves when we talk about COVID, for example, or our neighbors or family. And I think that's important to watch and see health as an holistic term, and not just about treatment and medicine and hospitals. And I think that's a key point.
That's excellent, thank you.
Yeah.
Dash, you're the face, the wonderful face that we see on our monitor in front of us, which is great. So I'm going to pick on you. What is, if you can, do the impossible task of what is, and when we know the data, This science has been excellent from us all. What's the key message? What's going to move hearts? What's going to change minds? What's the key message as you speak to public health professionals, as policy and decision makers? Over to you.
Well, it's quite multifaceted because it depends on who you're going to be speaking to. For public health officials specifically, there's already an impetus for wanting to do better for the community, wanting to make the community healthier and safer and be able to have a well-being. So having that data that shows how many people you can affect this change to, or what you need to be changed, and how that will affect community health. Now,
we've lost you temporarily. You were building up for the punchline.
Internet is unstable.
You're back again. You're back again,
Oh,
my friend.
excellent.
Please.
So it depends on, in political terms, it depends on who you're speaking to. Now, I know a lot of politicians that are very moved by community health and wanting to do altruistically, doing better. But in a real sense, what really moves a lot of politicians is a connection to public health and economics and the impact on budgets. The good thing is, the healthier we get people, the more economic benefit you can have back to your community, back to the cost on the state or on the federal government. You know, prevention is the most cost-effective way of reducing public health dollars that you need. It just happens to be an upfront cost. So connecting that economic outcast and forecast to your public health intervention of why it's needed and how you can do that is a much better argument. The good thing is those numbers will always be on our side because we know that a healthier community is one that does not need as much intervention. It just means we need to make that argument of why we need that influx of dollars now. So that's a lot of the connecting data that I can say has been most effective, as well as altruistically making a healthier society for not only people now, but future generations.
Thank you, sir. Thank you very much indeed. I do appreciate it. It was a highly compound question, but thank you for breaking it down for us. I'm going to run through my list, the who's who list in front of me. Corey, can I please ask you to go next? And again, just tell us, for you and your work, your constituencies, on what we know, on what you have discovered, what is the key message, if you could, which is going to make that substantial change or lead to that substantial change that we seek? Over to you, Corey.
Well, I think that the key message, I think, would really be, one about equity, and about when we look at a lot of different issues that are facing our cities, that a lot of them we have some common elements to, who is being most impacted and who's facing disparities. So all of these things are really interrelated. In terms of like what we need to be able to get there, I think that we really, around the world and virtually every context, we need better data on LGBTQ people, which, has been one of the focuses of my work. And we see that there's a lot more research than there was 10 or 15 years ago when I started doing this work, that's for sure. But everything is very fragmented. And so, when we were conducting this research, for example, and looking around the world, we found bits and pieces of things everywhere, but not comprehensive data, because LGBTQ identities are not being included in the vast majority of public health surveillance that's taking place around the world, including here where I live in the US. That's certainly not the case. So every day we're throwing away opportunities to collect data and have a more informed picture that, importantly, doesn't just let us see LGBTQ disparities, but looking within the LGBTQ population, where we know that here in the US, for example, it's mostly Black and Latinx, transgender people and queer people who are facing the worst of the health inequities. So just focusing it on LGBTQ people or just having research on LGBTQ populations without that intersectional approach is not going to be sufficient to even have the answer to what we need to do to implement solutions. So I think that that data message is really key, is that this needs to be a routine part of data collection so that we have the information that we need to really target our interventions and be able to deliver for the people who are in need of those services or whatever the case may be.
Excellent. Thank you very much indeed. Thank you. We're going to go a little bit quickly, and I'm going to ask, please, I'm going to do no justice to your wonderful name. Ludmila Legokstop. Oh my God, I've destroyed your name. Forgive me, please. Are you there? These are our two colleagues from Ukraine, because given obviously the current situation in Ukraine, I would very much like to hear, when we hear so much of the ongoing war, the ongoing conflict, please can you share with us what for you, what's that message you need to get out to the world right now from Ukraine when it comes to public health, public policy? And perhaps you could start by telling us all how you pronounce your wonderfully rich name. Over to you.
Thank you very much. Thank you for support Ukraine. And I can say very simple things that we need more support, we need more money, and we need that all the world be with us and stay with us.
Thank you very much. Absolutely, absolutely. And we're with you all the way on that. And our colleague Alexandra, are you still with us? If you are, from your point of view. Alexandra, what's the message to the outside
Yes, I'm with
world?
you. I wanted to say that no one program in our organization was closed with the beginning of the full-scale invasion. We just make bigger and bigger amount of services we provided to our clients. So I agree with Ludmila. We need some more money. We need weapons to finish this war and to live like we used to live before. Thank you.
We can all say amen to that. Okay, well, good luck, and our hearts are with you. We are rapidly coming to the end of our session. Before we close, colleagues online, colleagues in the room, colleagues, fellow presenters, are there anyone who would like to have a last comment, a last word? I'm sort of looking into the camera here, so my eyes go to all the presenters as well. Okay, as you're thinking of that, I would just like to say, look, I've learned a lot from this. I also heard of my takeaways, the good that we can do, even in a resource-constrained world that we exist in right now, by having an evidence showing the science in easy-to-understand terms. The cost of inaction. If we do not do something, what's going to happen? What of human rights? And if we are not inclusive, if we do not have an appropriate response, then we are simply going to make the problem far worse. And I think it's in everyone's best interest, including policymakers, decision makers. They, like us, they want to go to bed knowing that they've done a good job that day. They want to make sure that they have done the best possible. I'm quite sure that they have got the best bang from their dollar, to use the expression. They want to know that they've stretched their budgets in the best way. And the best way we know is to encourage participation, community-based action, the peer, the outreach work. This is what we need to absolutely get out, and that's my takeout, synthesizing what I've heard today, the human element. These are not statistics, they're not graphs. Indeed, as we heard, We are talking of real lives here, real people. We know certain groups often face stigma and discrimination. We all know too well. Many of the issues facing our colleagues, our friends from LGBTQI+ communities, and we know as well the worth, the value of having an appropriate response that does not discriminate. It's plateau, it's cliched, and UNAIDS often talks, as others, of cliches of let's leave no one behind. We need an inequalities approach, indeed. But of course, coming up with real live programs which start with a beginning, a middle, and finish with an end. What do we do? That's what I look to our presenters, our colleagues, people in the audience, to come up with some real-time evidence, real-time action. And from what I gather from the presentations, civil society, in all its wonderful diversity across the world, is standing up, and they're getting to the table, and they're answering that question. And for that, from UNAIDS, I'm saying a very sincere thank you. Would anybody like to have one last comment before we close?
Sure, I'll say something.
Please, Dash, go ahead. The floor is yours, sir.
No, I have enjoyed my time on the virtual side of the Fast Track Cities Conference, and for this session, we've learned a lot, and I'm very happy to have seen everyone's presentations. You know, one of the things about public health and financing public health and public policy is you will never receive diminishing returns when you make investments into public health, whether it's public health in equity, whether it's prevention, whether it's responses. You will never receive diminishing results. You're only preparing for what's next. And you're going to fix a lot of things that need to be fixed when it comes to health equality, health equity. And when we have a healthier society, we all benefit. So any investments you put into that and putting in places that you need it right now is crucial. And on top of that, you need alignment from top to bottom of policy and intention, health equity, and intention in what kind of health needs that your community needs and where that money is going to go, whether it's the federal level, the state, the county, the city. If you have alignment, you can make great things happen. So that's my final takeaway. So I hope that helps.
Thank you very much. And I don't think anyone could have a better closing remark than that. Just that one-liner, you'll never ever have a diminishing return when you invest in public health. And I think that has to be the clarion call for us all. Without further ado, I will say thank you very much again. My name is Dr. Gary Jones. I am the Senior Humanitarian Advisor with UNAIDS, and it's been an absolute pleasure being your moderator. Thank you all, and have a good day. Thank you. Goodbye.